Pediatric liver disease fortunately are rare, but unfortunately once they have it, it's usually for their life. So that's the difference between adult and children. Globally, I think the incidence is increasing because we are recognizing it more often. The children usually in the past, they died in the first few months of life, but now they survive. There are conditions which have therapies now, like treatment, like common liver disease, which leads to liver transplantation called biliary atresia. If identified early, can avoid or delay the transplantation for several years or decades. That is increasingly recognized worldwide. Diseases like viral hepatitis are going down with effective vaccination, improving sanitation, and effective antiviral drugs, unfortunately the ones they have it. So viral hepatitis may be not that big a problem in the pediatric age group going forward. But metabolic disease or inherited disorder the children are born with, that continues to be a problem. It's a diagnostic challenge everywhere. The availability of the investigations could be limited, and that affects the treatment and sometimes affects the prognosis. The difference between East and West or global will be that the Western world is increasingly seeing liver disease that is either inherited or their children are born with, while in our part or in India for that matter, infectious diseases still continue to be a major player. But I think it's changing as the time goes by. So if you look at children, liver disease in children, I think the biggest advance which has happened in the liver disease in children is the liver transplantation. And the last 3 or 4 decades, it has changed the whole outlook. In 1980s, there's a condition called liver tumors, hepatoblastoma. I'm giving an example where mortality was 80%. Nowadays, survival is 80% or 90%. So it has just completely turned on its heads. So then there are several therapies that have come up. These are which we come later on in a way in the future section, but those therapies have established now, like antivirals or new enzyme therapies, that is changing the face of changing the face and the outcome of liver disease in children. I personally believe, with some evidence, that liver transplantation is a disease. It's not a cure. Because once somebody gets a liver transplant, it's not their own organ, so they have to be on lifelong medication, and they need to take it, and they develop the complications of liver transplantation, which are technical or drug related. So the future is to replace liver transplantation with regenerative therapies. Now therapies could be at different levels. Either you do a gene therapy, or you replace a missing enzyme with an enzyme replacement therapy, or you regenerate your liver with liver cells, either the cells isolated from the donor livers or stem cell derived cells. So that is the future, I think, and that will happen. It's a matter of time. There are several bottlenecks we have at the moment. Initial data that we have is promising, but it's not as good as liver transplantation. So that's a kind of a challenge for us, because while we are trying to develop alternative therapies, there is a therapy that exists and works very well, like liver transplantation. So we are competing with a very well-established therapy. So for us to prove that our alternative therapy works, it's going to take longer and it's going to be difficult to prove it. That is the goal in a certain percentage of patients. There are 2 or 3 types of illnesses we need to take into account. So the inherited disorders where there is a single gene defect, there could be combination of gene therapy with cellular therapy. So you take the patient's cell, genetically modify it, correct the defect, and put those cells back into the patient's liver, and they regenerate. So that's one way of looking at it. Second is, if you have missing enzyme, you can directly target gene therapy and correct the missing enzyme by giving the gene therapy. Examples are Crigler-Najjar syndrome for that matter. But there are certain disorders where there is a lot of scarring of the liver, like biliary atresia for that matter. And that is a tricky group. And for that group of patients, I think for now, liver transplantation will continue to be the treatment till such time we develop therapies which will help treating fibrosis, which are several people are working on it. And once we have a combination of cellular therapy that are effective, fibrosis could be treated, then yes, that could replace. For the foreseeable future or beyond, maybe liver transplantation will have its place. Now, whether we can engineer the transplanted liver as the time comes by and make them immune tolerant. So I think having a liver transplant in expert hands is very safe and very effective. But afterwards, the complications that come with the usage of medication, which we call immunosuppressive agent, becomes a major factor, economical as well as the complication and other organ damage it can cause. But if we can develop treatments to treat the transplanted liver, either with what we call cellular therapy for tolerance, or develop some therapies where we can repopulate the transplanted liver with the patient's own cells, then the need for immunosuppression could be taken away. If that happens, then yes, then liver transplantation would work as a bridge to reduce the fibrotic or scarred liver, and then you can engineer the new liver and make it tolerant for the donor. So then you're taken away the immunosuppression. So those are the future. I think it's achievable because there are several technologies which are working in parallel. King's College has been in a way ahead of the curve because of the circumstances, the way it happened. That first liver unit in UK was started there in 1960s, and the critical mass kept developing. What King's College kept in mind or didn't lose the sight of was that they kept basic science, research, academics, and clinical together. So if you want to be a market leader or if you want to be ahead of the curve, you need to have three things together. You need to have a good patient population, you need to have basic science facilities, research facilities, and you need to have a translational arm to it. That means the treatment that you describe, you should be able to translate into the patients. And King's College has that infrastructure that differentiates it from many institutions. It has, under one roof, has basic science infrastructure, clinical patients, and research and education infrastructure. And that keeps that basic science facilities that we have is the glue that binds all the clinicians and basic scientists. So the fast tracking of the therapies that usually can take decades could be shortened to years rather than decades. India, what needs to do is, so there is no lack of talent in India, there's no lack of patients. I think what is maybe could get better with time is developing or investing in the research infrastructure, governance, and transparency. I think those three things are easily said than done. It takes time, but you've got to start somewhere. If we were to take over, in other words, change or get at par with the Western outcomes at the moment, outcomes are there, I guess. I don't know about the long-term outcomes. If we were to match that, I think then the infrastructure that is well established, well funded, and not always for profit, because that's where it becomes an issue. So it requires a government support, philanthropic support, and institutional support, whatever the institution, whether it's a government or a semi-government institute. Well, future is hard work because money is tight everywhere. But if your hypothesis is right, if your intentions are right, then I think everything can be delivered. It's just those two things have to be there right. And if you work in a good governance infrastructure, structure that has a transparency and proper governance, accountability, I think people trust you, people believe your outcomes, and if they can replicate those outcomes, that's where the test is. It's no good that one person does it and nobody else can replicate it. That's no good. So it has to be replicated by other people. The future would be, I think, it will be small molecules. First would be prevention. Let's put it that way. So if you look at adult words, most of the liver disease is preventable. Viral hepatitis is preventable or treatable, if not preventable, when those who get it. Fatty liver disease, which is the most common cause, is preventable and may be treatable. Autoimmune disorders are not preventable but are effectively treatable. So majority of liver disease in adults is preventable and treatable. In children, it's not the case. Genetic disorders can't be prevented. Yes, you can do a genetic screening, but then you're losing a fetus. But genetic modification of the defects is a real possibility now. There are clinical trials coming on gene therapy. There are clinical trials on enzyme replacement therapies. They're expensive. With time, they will get cheaper, but they're there. And everything is trying to avoid the need for replacing the liver. So the future would be regenerate, then replace.